Hello, I'm Dr. Anthony D. Benedetto, Medical Director of Bariatrics at Rochester General Hospital. I work with Dr. Alok Gandhi and a talented team of professionals to provide life-changing care. You're about to see a recording of a live session designed to help people understand the serious effects of morbid obesity, a problem that affects more people in our community every year. You'll also learn about surgical options that have brought relief for a lot of people who have tried more traditional forms of weight loss without success. Bariatric surgery is not for everyone, and it's not a path someone should choose without being fully aware of how it works and the full extent to which it can change lives. Our team is highly experienced in a variety of bariatric procedures. We've helped hundreds of people attain and maintain their goal weights and resume happy, healthy lives. After watching this video, you're bound to have questions. I encourage you to call our office at the number below for more information, or you can find out more at rochesterregionalhealth.org. Thank you again for your interest in our services. Along with bariatric surgeon Dr. Gandhi and the rest of the medical team, we would be honored to provide your care. Today, listen, we're going to talk about bariatric surgery. Let me tell you a couple of things about Rochester General Hospital. We are a center of excellence. Sounds important, doesn't it? We became a center of excellence 3 years ago, and we were just recertified a month ago. And that means that someone in the society came to see us, went through our program, looked at all of our data, and said, you know what, you guys are doing a good job, and gave us the seal of approval. What that means for you is you're going to get the highest level of bariatric care that's available. Okay? That's very important. This hospital has made a tremendous commitment to bariatric surgery. We have a bariatric floor, we have a bariatric operating room, we have a bariatric operating room team, we have bariatric nurses, we have all the equipment for bariatrics, okay? And Dr. Gandhi and myself, this is Dr. Gandhi, I'm the old guy. We both deliver the highest level of bariatric care that you can get. It's very important, okay? And one other thing is that we follow you for the rest of your life if you have an operation here. Okay? That's very, very, very important in bariatric surgery. This is not an operation. This is a program, okay? So 3 years from now, when you've lost 100 pounds and you're putting on some weight, I'm going to be on your back to get that weight off. Or I want to know why you're putting it on, okay? I follow your labs, and we follow your general well-being from a bariatric point of view. I do not replace your family doctor. I don't do what he does, okay? But he also doesn't do what I do, okay? And I want to make sure that you're happy from a bariatric point of view and that your operation is working and that you're doing well. So here's what we're going to do tonight. We're going to talk about obesity. It's a lifelong, progressive, life-threatening, costly, genetically related, multifactorial disease. That's the important thing. What you have to realize, if you're morbidly obese, you have a disease. It's like you have arthritis. It's like you have coronary artery disease. It's like you have diabetes. This is not something you've done to yourself. This is not a lack of willpower, okay? And what you have to realize is that when we look at the genetics, when people are morbidly obese, they can be probably nothing but morbidly obese unless we intervene and do something. And I want to make the differentiation between people who are overweight or obese. That's one set of diseases. Being morbidly obese is its own separate disease. Okay? Very important. Next. We're going to talk about morbid obesity, and that's clinically severe obesity, at which point serious medical conditions occur as a direct result of the obesity. If you're morbidly obese, chances are you have sleep apnea, you're diabetic, you have high blood pressure, you have high cholesterol, polycystic ovarian syndrome, all because of the obesity. Okay? How do we define that? If you are 100 pounds above your ideal body weight, you're morbidly obese. Or, more importantly, if your body mass index is 40 or above, you're morbidly obese. Hang on to this number 40. It's going to come up a whole bunch tonight. Next. So what causes obesity? It's simple. It's energy in versus energy out. If you eat 5,000 calories a day, you have to burn 5,000 calories a day, or else the excess gets stored as fat. Simple, right? Let me give you an example of that. I get on a treadmill in the morning. I go 2 miles. How many calories do I burn? 200 calories. Let me put that into perspective for you. 2 miles on a treadmill, that's 1.5 chicken wings or 2 Oreo cookies. That's it. Okay? A lot of people tell me that they're going to go to the gym and lose weight. Doesn't happen in the gym. Not unless you're a marathon runner, not unless you're going to ride the Tour de France. You are not going to lose weight in the gym. You're going to get healthy, but you're not going to lose weight. Obesity is multifactorial. There's a lot of factors. I left this slide in because this slide is actually wrong. We used to believe that genetics was 25 to 30% of this disease. Now we know that genetics is over 80% of this disease. Okay? There are neuroendocrine diseases that we don't want to operate on, and there's environmental factors and metabolic factors, and we're going to talk about all that. Recognize this? This is every food court USA. There are companies in this country that have figured out very smartly how to give you tasty, satisfying calories fast for a little bit of money. Big Mac fries in a shake, how many calories? 1,000? I wish. All right. Depending on how you build it, it can be anywhere from 2,000 to 2,300 calories. That is more than your daily requirement in one meal. And if you're morbidly obese, that's twice your daily requirement, okay? And they're satisfying calories, satisfying calories. So that's one problem, is that we have a lot of fast food that is not exactly the healthiest food for you, and it's around and it's easy. Next. This is the second part of the problem. How many people walked here tonight? How many people walked to get a paper today? How many people walked to get a quart of milk? So now we put in 2,300 calories, 2,000 calories in one meal, and we hop in the car, and we burn very little calories. So this is how the problem of morbid obesity gets to rear its ugly head. Next. Let's talk about body mass index, very important. It is your height, your weight in kilograms divided by your height in meters squared. Next. That's not what we do. When you come into the office, we measure you and we weigh you. Simple. If you're 5'2", and you're 260 pounds, your BMI is 48, you're morbidly obese. If you're 5'2" and you're 300 pounds, your BMI is 55, you're super morbidly obese. Remember, anything above 40 is morbid obesity. If you are 5 foot and you're 300 pounds, your BMI is 59, almost super morbidly obese. Above 60 is super morbid obesity, okay? Very important, because that's the definition of morbid obesity. Next. Let me give you a couple of reasons not to be morbidly obese, okay? This is a mortality risk table. It tells you your chances of dying versus your body mass index, or your BMI. So if you look down here, if your body mass index is 20 to 25, normal weight, your chance of dying is 1. It's the same as the normal population. If you're overweight, 25 to 30, it goes up a little bit, but not a lot. If you're obese, 30 to 35, you have 1.5 times the chance of dying as the normal population. Look what happens when you hit BMI of 40. You have 2.5 times the chance of dying as a normal population just because of the obesity. Now, BMI is pretty low where I live, okay? The biggest person I ever operated on had a BMI of 86. So this curve just keeps going up this way. So a good reason not to be morbidly obese, it could kill you. Next. Is this a big problem? Yes, it's a worldwide problem. It affects 25% of the industrialized world. We have 34 million adults that are overweight. 25% of our children are overweight. We have 5 to 11 million people in this country who are morbidly obese. We spend $238 billion a year, and yet 300,000 people die every year of this disease. That's a big problem. Next. Bear with me, a busy slide. If you look down here, if the state is white, there's no data, okay? If the state is light blue, excuse me, less than 10% of that state's population is obese. If it's medium blue, 10 to 14% of that state's population is obese. Dark blue, 15 to 19%, and red is greater than 20% of that state's population is obese. Are you with me? Okay. Let's go back to 1991. A lot of medium blue, light blue, and a little bit of dark blue. We jumped just 4 years later. Medium blue and dark blue. 5 years later, dark blue and red. That's how fast the problem of obesity is growing in our country. And that's happening throughout the rest of the world too. Europe has a terrible problem, Australia has a problem, and even Mexico has a problem. And even now China is beginning to have a problem with morbid obesity, believe it or not. Next. Here's another reason not to be morbidly obese. Your chances of having esophageal, breast, uterine, ovarian, prostate, colon, and cervical cancer are all increased with obesity. 3 separate studies, 3 different years. Any questions? No. Next. Drug therapies, Xenical. Anybody try that? It's called Ally now. Meridia, phentermine, anyone use that? Any fen users from the past? No. These aren't bad drugs, but they don't work for people who are morbidly obese. They work for people who are overweight. They work for people who are obese, but not from people who are morbidly obese. How many people in this room have gone on a diet and lost 50 to 100 pounds? How many people have gone on a diet and have lost 25 pounds in this room? Okay. You can lose weight, right? That's not the problem. The problem is keeping it off. Let me give you some statistics. If you are morbidly obese by strict criteria, BMI is 40 or above, and you go on a diet and exercise program and you lose 50 or 100 pounds, your chances of keeping that weight off is less than 5% in 5 years. Let me put it to you another way. If you're morbidly obese and you go to your doctor's office and he puts you on a diet and exercise program and you're morbidly obese, he just puts you on something that's going to fail 95% of the time in 5 years. Let me ask you a question. If diet and exercise would work for morbid obesity, who would ever have an operation? If anything would work for the treatment of morbid obesity, who would have an operation? No one, right? But after this has been studied for many, many, many years, we've come to realize that the only long-lasting therapy for the treatment of morbid obesity is surgery. And I'll give you some statistics in a little bit. If you're obese, your chances of having diabetes is 14 to 20%. High blood pressure is 25 to 55%. High cholesterol or hyperlipidemia is 35 to 53%. Heart disease is 10 to 15%. Sleep apnea is 10 to 20%. Arthritis is 20 to 25%. Depression is 90%. stress incontinence is 50%, and menstrual irregularity is 50%. All because of the obesity. Is everybody good and depressed? No? Yeah, okay. This next slide is going to cheer you up, I promise you. Next. This is really the most important slide that I have to present. This was a study done by a Dr. Whitgrove and Clark, published in 2000. Dr. Whitgrove and Clark were the first doctors in San Diego to do laparoscopic gastric bypasses. And they did 500 patients. Everyone had great weight loss. But these doctors asked a more important question. What happened to the diseases that were associated with the obesity after people lost the weight? Are you with me? Okay. Here's what this study found. 95% of the patients lost their type 2 diabetes. A lot of times that'll happen in 3 days. High blood pressure went away 92% of the time. Heart function improved 95% of the time. Osteoarthritis improved 82% of the time. Sleep apnea went away 75% of the time. Stress incontinence went away 87% of the time. Gastroesophageal reflux disease, or GERD, went away 98% of the time. And the cholesterol improved 97% of the time. This is the reason why people have bariatric surgery. People don't want to be sick anymore. People don't want to be sick anymore. This, to me, is amazing. It's absolutely amazing. And the fact that if you're morbidly obese and you have type 2 diabetes, there's an operation that can control that, to me, is amazing. You know, in 2008, the American Diabetes Association, the ADA, put bariatric surgery in their algorithm for the treatment of morbid obesity. Okay? To me, it's amazing. I am amazed every time I operate on somebody and they come back in and say, I don't take any more diabetic meds. Fantastic. All right, let's move on. Next. The non-medical comorbidities. Next. Physical comorbidities. Clothing choices. Tying your shoelaces. Furniture incapacity. Okay? You know, if you're morbidly obese and you don't fit in an airline seat, which isn't very big, you know what happens, right? You pay for 2 seats. Right. Okay? And personal hygiene, there's nothing to say about that. Next. Employment discrimination and education discrimination. Studies have shown that if you are morbidly obese and you are up for a job or a spot in a university against someone who is normal weight, the normal weight person will get that job, okay, regardless of the qualifications. It's very sad to say. Next. Major psychiatric illnesses are the same. Things like schizophrenia and paranoia. They're the same in the morbidly obese population and in the normal weight population. But if you look at depression, in the normal weight population, depression is 20 to 25%. In the morbidly obese population, depression is 90%. And we know this is one comorbidity that does not go away. Okay? People feel better about themselves. People are very happy that they had surgery, but they still need to take their antidepressants. Next. Weight harassment. Studies show that there's very low respect for morbidly obese patients. Limited number of friends, and dating and marriage is less common. This is all stuff that you know. Next. So why surgery? Diet and exercise is not effective long-term in morbidly obese patients. We know that. We've studied this. Surgery is accepted and effective. It improves your comorbidity. That's what I think the most important thing is. What you have to do is weigh the benefits of surgery versus the risk of staying morbidly obese. This has been studied in McGill University. your chances of dying are 6.34% higher if you don't have the operation. And that takes into account the risk of surgery and also the risk of staying morbidly obese. Next. The National Institute of Health Consensus Conference, 1991. Seems like a long time ago, but the society does not want to change it because really nothing else has changed. After they've studied this problem, here's what their consensus was. Surgery is an accepted and effective approach that provides consistent, permanent weight loss in morbidly obese patients. Who should have the operation? If your BMI is 40 or above, or if your BMI is 35 to 40 and you have significant comorbidities. So if your BMI is 37 and you're diabetic, you have sleep apnea, you have high blood pressure, we can get you approved. Okay? And you have to have documented dietary attempts that have been ineffective. Okay? Insurance companies want to see that at least you try dieting. Okay? Even though we know it doesn't work. Next. So who's the surgical candidate? You meet all the NIH criteria. There's no endocrine causes of obesity. You have to be an acceptable operative risk. You have to understand surgery and the risk, and we will go over the risk with you, and I do that personally in my office. There can't be any drug or alcohol problems. If there's a drug or alcohol problem, you have to be free for a year, and you cannot smoke and have this operation. Very important. No uncontrolled psychological conditions. And after the whole bariatric team evaluates you, which includes obviously the bariatric surgeon, the nutrition, your family doctor, and a psychiatrist. After everyone says you're a good candidate, we put you in for approval and we go ahead and operate. This is the most important thing. You have to be dedicated to a lifestyle change and follow-up. This should be number one, okay? I'm going to tell you a story, true story. A very, very big lady who lived west of here came in, she went through the program, we did a Roux-en-Y gastric bypass. And she came in, she lost 70 pounds like this. 70 pounds like that. She came in, she said, "Doc, I'm not losing any more weight. I expected to lose more weight." So I did some studies, I did some endoscopy, I did some x-ray studies, I did some labs, and everything came back normal. She came into the office and we were going over all of these results. And she said, "Doc, you think maybe it's the chocolate I'm eating?" I said, "What do you mean?" She said, "Well, every day I get up and I get this bar of chocolate and I just break off a little piece and I eat it all day long." True. I couldn't believe my ears, but it's true. If you're going to do that, don't have the operation. Don't have the operation, because she didn't do any changes in her lifestyle, okay? You know, I will tell you that with this operation, it's kind of like magic for the first year. And then it's not magic anymore, okay? No matter what you do in that first year, you're going to lose weight, and you're going to say, "This is terrific," okay? And I call that the honeymoon year. But it's the second year and the third year and the fourth year where the weight starts to creep up a little bit. And you need to control that. You need to control that. You need to exercise, okay? You need to monitor how much you're putting into that sleeve or that pouch, okay? Very, very important. You know, my wife, who knows a lot about bariatric surgery, she coined a term, and she calls it head hunger. And everybody in this room knows what head hunger is. You know, we go through 500 channels on the cable, and there's nothing to watch. We look at every magazine in the house, and there's nothing interesting to read. And then we think the refrigerator. And we get to that refrigerator and we do this. And we look for entertainment. We don't eat because we're hungry in this country. We eat because we're looking for satisfaction. I can't do anything about that. I can't do anything about the head hunger. Okay? That's something you have to control. And I will tell you, you need to come to grips with that. Because everyone tells me, I got this under control, doc. Let's go to the operating room tonight. Let's do it tonight. Okay? Let's do this tonight, because I got this under control. But you really have to say to yourself, do I have this under control? Am I going to make lifestyle changes and be dedicated to them? Very important, and I leave that with you. So who has this operation? 80% of women, thank God. Everybody knows that men are babies. Most people are 25 to 45. My patient population is different. I don't know why, but I've operated on a lot of elderly, middle-aged people, okay? The oldest person I've operated on was 76, and I've operated on a bunch of 72-year-old people. People have often been overweight since childhood. They've undergone a lifetime of discrimination. Most people will tell you that they've tried 10 diet and exercise programs unsuccessfully before they start to think about bariatric surgery. And most people do about 2 years of research before they wind up in an informational session, okay? I will tell you that the bariatric population is very educated and knowledgeable because of the internet, okay? They go on the chat groups and they know what's going on, okay? And they know what operation they want and they know the results. And I think the internet helps them and helps everyone in this situation. Next. Let's talk about these operations, shall we? Okay. I'm going to tell you a story, and I'm going to draw you a picture. About 10, 15 years ago, bariatric surgeons were faced with a difficult problem. We had very big patients, 500, 600, 700-pound patients who were not very healthy. And we needed to do their operation, but we wanted to do it in 2 stages, two steps, okay? And after the first step, we hoped that they would lose a bunch of weight. And then after they became healthier, weighed less, we go back and do the second part, okay? Fair enough? Easy to understand? So here's what they did. The first part was going to be a gastric sleeve. And what we do is here's your esophagus and here's your stomach. There's a valve between your stomach and your intestines. Okay? So we put this tube in here as a measuring guide for us. Okay? And then we measure about 1 inch from that valve. And then what we do is we staple, 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 staple. And we take all this out. So then they did this operation, and they observed these patients, and they found out that these patients lost as much just with the sleeve as a gastric bypass. And a lot of patients never went back for the second part of the operation. These patients lost 60% of their excess body weight. A gastric bypass, 65%. So people started doing this as a primary operation, just this. This now is the most popular bariatric procedure in this country. And it beat a gastric bypass, which was the #1 since about 1967. Okay, that was the gold standard. This is done laparoscopically with a bunch of little tiny incisions. Okay? Very rarely do we have to open you up and do this through an open incision. Okay? Very rarely. Okay? And I would say that's less than 2%. Gastric sleeve. This is the most, this is my most common operation. I probably do 90% of this. Okay? There's lots of reasons why I like this operation. Number one, we don't play with your intestines, so we decrease the risk of bowel obstructions. If you've had a lot of previous surgery on your belly and your intestines are all matted together with scars, I don't have to worry about that. Okay? If you have things like severe arthritis and you need to take medication called non-steroidal anti-inflammatory drugs, Motrin, ibuprofen, you can take them with this. You can't take them with a gastric bypass. You'll get an ulcer. Okay? If people have inflammatory bowel disease and we don't want to bring up diseased intestines, I've done that on 3 or 4 patients with inflammatory bowel disease. Okay? Gastric sleeve. I'm very, 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 very impressed with the results. Okay? The metabolic effects are not as great, especially on diabetes, as a gastric bypass, but there still is a beneficial effect to diabetes. Very important. Anybody have any questions? Yes, sir.
What is the functions of the excess stomach that you're going to be removing? What's the function? What is this?
Well, the question is, what is the function of the excess stomach? Well, the excess stomach allows you to eat more. Okay, that's not what we want. Okay, but there's something also very important with this part of the stomach. There is a hormone up here that's made right up here, and it's called ghrelin. And that's the hormone of appetite. That's the hormone that makes you hungry. And we take out that part of the stomach. Now, if you ask me definitively how a gastric sleeve works, I'm going to tell you, I really don't know. Because I can't explain all the metabolic effects that we get from this operation, but I will tell you that it just works. And I think that it's going to require a lot more studying to figure out exactly why it works, because it doesn't act like just a restrictive operation where we decrease the amount you're eating. Okay? We see all these metabolic effects like we see in a gastric bypass. Okay? Very, very important. Any other questions? Yes, ma'am.
So I understand the importance of like the medical reasons for the surgery, but I'm also thinking about the saggy skin. So is there like a operation that, is it the age that stopped that?
Right, okay. All right, so the question is, after I have a sleeve or any bariatric procedure and I lose all this weight, I'm going to have excess skin, right? All right, then you become very friendly with a plastic surgeon, okay?
So it's going to happen?
Well, if you lose a little bit of weight and you're young and you haven't had children, sometimes the skin will contract a little bit, but don't count on it, okay? Here's my feeling about that. When I see the excess skin, I kind of like it because I know my job is done. And you might have some excess skin, but you're healthier. That's the important thing. So there's 3 kinds of bariatric procedures. There's a malabsorptive procedure where we rearrange things so you can't really absorb the food that you eat. There's a restrictive operation where we just can't put enough in, okay? And then there's a combination of malabsorptive and restrictive. We're going to talk about each of these. Next. This is the vertical banded gastroplasty. This is the stomach stapling of years ago. We don't do this anymore. I just show you this for historical interest, okay? But this was a restrictive operation, and we just restricted the amount that you could eat. We don't do it. The operation failed a lot of times because the staple line broke down. Next. This is a biliopancreatic diversion with switch. This is a malabsorptive operation. And this is the operation they were going to put these people through in 2 stages. So if you look up here, there's your sleeve, right? And then we bypass your intestines, but we hooked your intestines to your duodenum, not to your stomach. Very, very, very effective operation. You can expect a 77% excess body weight loss in 5 years, okay? One of the problems with this is if we bypass your intestines too much, you can get protein-calorie malnutrition, you can get electrolyte abnormalities, you have to be on very expensive special vitamins and have this operation, okay? So, but this is a great example of a malabsorptive operation, okay? Next. This is a lap band. This is a restrictive operation, and inside this lap band is a balloon, and that balloon goes to a port underneath your skin. And what we do, and I will show you this, inside here is a balloon. And this port goes underneath your skin, and this goes around your stomach. So when you have a lap band put in, you come into the office, and we stick this port, and we inject fluid, and that blows up the balloon and pinches off your stomach. Okay? So you have this little tiny pouch up here. Okay? So what you eat can't go down, you feel full, and you lose weight. Okay?
But you still got that part of the stomach.
You have the whole stomach, right? You still have the part of the stomach that says you're hungry, right?
I'm trying to stuff stuff down.
I have probably put in more lap bands in Rochester than anyone, and I have taken out more lap bands in Rochester than anyone. I don't do the operation anymore, and I'll tell you why. I have people who've had exquisite, tremendous results. I had one lady lose 300 pounds with a lap band. And I've had other patients not lose 10 pounds with a lap band. And I can't figure out who's going to do well and who's not going to do well. Because of that, I think you should have one operation that I know is going to work for you. Okay? The lap band was very popular in Australia, and they're really the proponents of it. But people in this country can't duplicate those results, and we don't know why. And I will tell you, there's not very many people putting in lap bands anymore. Okay? Next. This is the Roux-en-Y gastric bypass. This, in this country, is the gold standard of operations. If you look up here, here's the whole stomach, okay, as big as a football. We make a tiny little pouch. That pouch is as big as my thumb, literally. That's how much food you will eat. And then we bypass the intestine, so the food you eat, you don't absorb. Okay? This was first done in 1967, first done laparoscopically in 1993, okay? And you could expect to lose in the first year 65% of your excess body weight loss, and you get all the beneficial effects that I showed you in that slide before, okay? Very, very excellent operation. I don't do a lot of them anymore, but if there is a specific need, if someone's a severe diabetic and they're morbidly obese, I'll probably recommend a gastric bypass, because I know that the gastric bypass works better for diabetes than a sleeve does. The question is, if you leave this part of the stomach in, once someone loses the weight, can you reverse the operation? And you know what will happen? All that weight will come back. All that weight will come back. We leave this in here because there's really no need to take it out. Okay? And if you ever developed a problem with your esophagus, like an esophageal cancer, we actually use this to reconstruct it. Okay? So it doesn't have to come out. It's pink, it's healthy, it's happy in there. Okay? So we just leave it. But you don't want to reverse it because all that weight will come back. So how does the Roux-en-Y work? We restrict the size of your meal. Okay? If you eat sweets, you'll get the dumping syndrome, which is water will follow the sweets into your intestines. Your face will get very red. Your heart will beat at about 140 beats per minute, and you'll have the worst diarrhea that you ever had. And I used to think that the dumping syndrome was a bad thing, but your body's trying to tell you don't eat the sweets. Okay? You have some malabsorption, and I will tell you that if you talk to anyone who's had a gastric bypass or a sleeve, they tell you that they don't feel hunger like they used to feel. Now, the head hunger doesn't change. We got to get this under control, okay? But the usual appetite is usually gone. A lot of patients who had gastric bypass will tell you they forget to eat. All right? So what happens is they're on a nice diet. They're eating what they want, only extremely small portions. They're taking their vitamins, okay? And they come in, they get on the scale, and in 2 weeks they lost 15 or 20 pounds. Now they're very excited because they don't feel hungry. They don't feel like they're suffering through a diet. And the first thing they ask me is, when can I start to exercise? So now they start to exercise, they're burning more calories, they lose weight. Okay? Next. So the results of bariatric surgery, there's weight loss. We improve the comorbidities. I think this is the most important thing. We increase your longevity. That's been studied and shown. And your quality of life is overall, I think, better. I've never had one patient regret having this operation. And I've had one lady say that she would do this once a year if she had to. Mm-hmm. Okay? Next. This is a couple of studies from Dr. Higger and Boom. This is the long-term results of laparoscopic gastric bypass. They did 850 patients. 89% of the patients were followed for 5 years. Their preoperative BMI was 49. Current BMI was 31. Okay? Their average weight loss was 105 pounds. They felt that there was 79% success. I don't believe this. I think this is much higher. They thought it was excellent if the BMI was less than 30, but I think these are very, very good results overall. Next. This is Dr. Whitgrove and Clark that we spoke about before. They did 500 patients, like I said. They followed them for 3 years. They had 80% excess body weight. I think that number is high. I would still say it's 65%. They had 96% of their comorbidities controlled. As far as complication, they had less than 1% leak, and the mortality rate was less than 1%. Okay? Next. You cannot discuss bariatric surgery without discussing complications. Okay? This is serious, serious business. Okay? And we do it well, and we have very few complications, but when there are complications, they can be life-threatening. So we need to talk about that, and I personally will talk to you about complications before you sign your consent, before you signed up for surgery. The biggest thing that we worry about is intestinal leakage. When we do this, this is all with staples, okay? If that doesn't heal properly, it'll leak, and if you leak, you'll get very sick. We go right back to the operating room, we clean it up, we put you on antibiotics, but you could die from the infection, okay? And you have to understand that. Acute gastric remnant dilatation is something we don't see anymore, or very rarely. It's where the old part of the stomach kind of blows up. We don't see it very frequently. And if we do, we just get a CAT scan and we decompress it, and things are usually okay. Bowel obstructions are much more common with a gastric bypass because the intestine is rerouted. Cardiopulmonary complications, acute MI we don't see a lot of because we have people evaluated preoperatively. And if they have heart disease, we usually get a stress test and we get a cardiology clearance. But a pulmonary embolism, a PE, that's a blood clot that breaks off from your leg and goes to your heart. Goes through your heart to your lungs. That is the most common cause of death in a bariatric patient. 50% of all deaths are pulmonary emboli. At Rochester General, we go to great lengths to avoid that. You have special stockings in surgery. We give you medication to thin your blood. And after surgery, you will walk every 4 hours around the clock. Okay? But you have to know about these things. Pneumonias are very uncommon now, and atelectasis, very uncommon. That's just a little collapse of the lung. Late complications, you can have a narrowing where we put your bowel back together. Not a big problem. Dr. Gandhi and I just do a scope. We pop it open. You go home the same day. Anemia is B12 deficiency, calcium deficiency. Not really an issue here because we follow you at least once a year with laboratory data. Okay? And we will track you down. Okay. Next. You all notice the difference? Yeah. No dog.
Right.
Okay. Questions? The question was, will you operate on a patient with a factor V Leiden deficiency? And the answer is yes. We do that all the time. Okay?
Yep.
Yep. Questions?
What about someone who had heart failure twice and high cholesterol?
Well, I would have to find out why they had heart failure.
Pregnancy.
Well, then the heart should be better, and we need to have a cardiologist evaluate the function of the heart. And then if they say that you can undergo surgery, we need to have special anesthesia that concentrates on that heart, and we can do that here. Okay? The longevity of how long this is going to take depends on the insurance. Should you call your insurance company? No. When you come in, we'll know what your insurance company requires because we do this hundreds of times a year. Okay? That's all you have to do is show up and let us take it from there. Okay? One of my girls is an insurance expert. You can tell her your insurance. No, it's my other girls. Lori, who probably went home because she had a long day. But she knows everything about this. All right?
All right.
All right. And believe me, we want to get you from the first visit, okay? We want to get your operation done. That's our goal. Okay? Yes, ma'am. The question is, okay, what is my favorite operation? Okay? I could give you the answer to that, but that's not the way it works. What I really try to do, and you actually come into my office and sit down, and we talk about your medical problems, and you tell me what operation you're thinking about having, and then I will kind of try to guide you to have the right operation, okay? So I tell people this all the time. They ask me, who gets to pick my operation? I say, you do. I just won't let you make the wrong choice. All right?
So if,
let me cut across you one more time. I'm very serious with all of you. We sit down in my office, just you and I, and talk about this with the door closed as much time as you need, because that's very, very important time. Okay? Because I have to get to know you, and I have to get to know all your medical problems, because I'm trying to solve a lot of those medical problems. So the operation will come from that encounter. The question is that if you get in tomorrow, how long does the process take? It really depends on your insurance company, okay? It depends on what they demand. A lot of insurance companies want you to be weighed for 6 months, okay? I can't do anything about that. And I don't try to put anything over on the insurance companies, okay? And I have a great relationship with the insurance companies because they know what they get from my office is the truth. It also depends on how fast you do all the stuff you need to do, okay? But we can get you done, and believe me, in my office, we are trying to simplify this process. So if you want to be seen, just make an appointment. Do not call tonight. If you call tonight, my service will call me, and I will get very, very angry, okay? And you'll get an appointment probably next July. Thank you all.